Okay, hello guys. Just doing a video on how to spot the problem. So, quick disclaimers for people watching. So just make sure you pause it and read the whole thing before continue watching. So this is to do with the case that I posted up on my social media a few days ago. If you're watching a bit later, pause the video, have a look at this case and see if you can work out all the potential problems before you give out the meloxicam. So I first posted this on my Facebook group. It's actually based on a real person that came into the pharmacy. So I found it interesting because I did notice a lot of problems that I had to rule out before giving this patient meloxicam. Originally, I was going to turn it into an exam and then do that probably in the next workshop that I do. But I decided to try something different. So I posted it in my Facebook group first. They seemed to respond well to it. So then I posted it on my social media, Instagram, Facebook, and stories. Got quite a few DMs on people trying to work out the problems. There was not that many that got all the problems. Quite a lot. Well, I think nearly everyone that DM'd me got at least one of the problems, and still a lot of people got two of the problems, but there was only a couple that got all of them. So I thought I'd do a big video breakdown on the whole thing and how to spot the problem. So in this case, there were three major problems to spot and a few minor ones. So just before moving on, I'll just loosely define a major problem as the severity of the adverse event. So how bad it would be if this was to occur versus the probability of it occurring. So the likelihood of it occurring if you were to continue. So for the students or interns that were DMing me, quite a lot of them I was responding with, that's not really a major problem in this case, but it's probably a minor one. So it's to do with how I've defined it. This is a loose definition. I don't think it's a technical one anywhere. So major problems we are looking for, and we'll go through the minor ones. So this is just what we'll cover. So we'll go through the whole list, then we'll go through how I would turn this case into an exam, whether it be for your OSCE at uni or your intern oral exam. And then we'll do what to do if you don't spot the problem. So first part, is there a problem with this medicine? So we'll start with salbutamol and work our way up. So dose, we've listed it here as 2 puffs every 6 hours when needed. So I did have one student query it, so meant to be every 4 hours. Think that is because different references kind of have it differently. So the AMH has it as 3 to 4 times a day, which makes it every 6 hours. The CMI for asthma or Ventolin has it as every 4 hours. So this may be where this student's getting it from. Not a big deal. You'll see really big differences depending on the prescriber. And like for first aid purposes, like they use it every 4 minutes. So you do get quite a large difference between how often people are dosing it. So not really a big issue here, but good thing to query, I guess, if you're a student. So then we can look at potential interactions. So there's obviously a lot of things that you can check. Dosing interactions are probably the main ones for this one, since we're not questioning the patient. So we've got drug-drug interactions. So do drugs interact with another drug, or drug-disease interactions? So do drugs interact with diseases? So in this case, there's no real kind of drug-drug interactions, but there are potential drug disease interactions. So this person most likely asthmatic, and we're about to prescribe meloxicam. So can you think of a drug disease interaction there? And if you can, you most likely would have got bronchospasms with the meloxicam use, as one student said. NSAID triggered exacerbation of asthma. Another student, NSAID making the asthma worse. This one's a good one. So they've quoted the AMH under the precautions bit. So it could potentially make it worse. And they've noticed that they were on prednisolone a few days ago. So they've trying to tie a few things together, thinking that maybe the prednisolone was a result of the an asthma exacerbation, which is good. So you can see they're trying to think ahead. This was a really good comment. So they've specified that meloxicam is COX-2 selective, which it is. And then they've mentioned that it can still cause bronchoconstrictions, but it's most likely less. That's the implication, that even though it's COX-2 selective, it's less. So this was honestly something that I had to double check because I wasn't too sure. So really impressed with this comment. But I'll just quickly show you my favorite comments before I'll address this further. So I had this beaut of a comment. Person has asthma, so he is cooked, or she. So very technical wording there, being cooked. So that is our first major problem there. Major problem. So back to the comment that this person did. So COX-2 selective. So I double checked this, and it does look like it's correct. So there's a basically a screenshot of a study that was done. So we just go down straight to conclusions. COX-2 inhibitions provide potential safe alternatives for treatment of inflammation conditions in patients with asthma exacerbation respiratory disease. So good on that student or intern for picking that up, that there's less of a risk with meloxicam, but there's still a bit of a potential there. So yeah, good job. So I've said that that is one of the major problems. So basically, we don't know whether they're sensitive to NSAIDs, but we basically don't know. If we give it out, there's potential that they are, so it could make their asthma worse. And if they are sensitive to it, then their likelihood would happen. And then the severity of it is quite high. So that's why I've listed that as a potential major problem. So let's move on to salbutamol. So not salbutamol, Symbicort. So here's our Symbicort. So I had quite a lot of students or interns, don't know who they were. I know there was a mixture of the bunch. Query the dose. So they're saying that it should be daily, not PRN, basically. So not a reliever, not really use PRN. Symbicort should be used regularly, not PRN. Quite a little surprised at that. So basically, Symbicort can be used PRN. I did not want to take a picture of my AMH, as that will look a bit silly. So this is just a screenshot from the CMI. So Symbicort Turbuhaler can be used when needed. It is also used as a reliever, and it can be used every day as well. So basically, that is probably to do with the fact that they were not taught properly at uni. So usually if you don't know something, it's either it wasn't taught properly, or you have not been kind of proactive enough about your own learning. So since these people have been messaging me, it does kind of imply that they are quite proactive about their learning. So most likely they just weren't taught that properly. So often you just really taught that it's just basically salbutamol or Brucanol, which are relievers, and then everything else is a preventer. But Symbicort does work quick enough for it to be used as a reliever as well. So yes, it's one of those things that just need to be a bit careful of. There were obviously a few students that were saying that. So the dose is okay. It can be used to BD. So this patient's using it twice a day. So twice a day regularly and required. Starting to see dosages like this a lot more common in community pharmacy, where they're using it both as preventer and reliever. So interactions, did have one student mention one thing. So they said that the steroid in it could be increasing the risk of the ulceration and potentially high BP. Probably unlikely, since it is an inhaled dose. We're not expected to really get that. Probably, I imagine maybe it's just flagged automatically on MIMS, and that's why they're thinking that. But good as a learning thing to double check these things. So not really a likelihood that that would occur. Had a lot of students or questioning the compliance and the appropriateness, which was good because I honestly something I didn't think of when I was looking at this case either. So it's good to be learning from you guys as well. So here they're basically saying Symbicort and Ventolin, they both can be used PRN. So they could really just only use one. So what's the appropriateness of having both Symbicort and Ventolin PRN? Here's a really good, nice message that I really appreciated. So they just said, instead of having two separate inhalers as PRN, they should only be on one Symbicort, not Ventolin, and that it has been 2 months since it has last been dispensed. So here they're double checking if there's a problem with compliance, which is good. So if it was obviously a real life example in an exam or just in real life, that they would double check it. And then they leave me a last message saying, thank you for the advice. It means a lot. I've been reading through your book. So they're referring to how to pass the Pharmacy Australia into an oral exam. And it seems like it's helping them a lot. So really appreciate messages like that. If you're ever reading stuff and you find it useful, feel free to shoot me a message. I do like seeing them. And then this person, good comment as well. So Ventolin and Symbicort as PRN, they won't need both. And then they just mentioned that formoterol is quick acting, which it is. So that's why we can use it PRN. So for the purpose of this one, there were not really any real proper issues. These are all just kind of small things. So nothing really that bad would happen if you didn't talk about how they're using Ventolin or Symbicort. As long as they were using both of them, that'd be fine. And you'd imagine they would. If they're asthmatic, they would generally have one on hand. But good to, you can probably increase their medical knowledge by talking to the patient here. So just kind of really small things that you can probably increase their health literacy a little bit with, but nothing major, basically. So Symbicort, some little minor things if you want to speak to the patient, but nothing major. So prednisolone. So we've got this patient on 25 milligrams and taken 2 a day. So that will be 50 milligrams for 5 days only. So I did have one patient, not patient, one student or intern ask about the dose, querying when it's below too high. So 50 milligrams for 5 days, that's generally okay. Yeah, generally okay. You do see dosages like that. I think it's within the guidelines as well with the AMH, just double check that. And then one person queried about needing to be weaned off, which is a good thing to double check. Weaning is a different, I don't think there's an exactness to it, especially at these short days. Certainly when you start going over a week or two, you definitely start weaning. But for these kind of really short days, 3 to 5 days, you will see some doctors wean it. Some doctors will not. It's not, yeah, this one's, I would not be too concerned if they didn't wean, but I wouldn't be surprised if I did see it since it was starting at 50 milligrams. Certainly if it was a lower starting dose, I wouldn't be surprised at all if there was no weaning, but not really a big issue here either if they don't wean it. So any potential interactions? So we did have some students point out the potential interactions between prednisolone and meloxicam, which was good. So even though it says it's only for 5 days, patients are often given the whole bottle, and sometimes they are given separate guides on how to reduce it from the doctor. So it may not be on the actual prescription instructions. So it's good to double check whether the patient is still on this, even though it said it was only done only for 5 days and it was over a month ago. But still good to double check if they are actually still taking it. For this real life example, when I was talking to the patient, I did double check that as well to make sure they weren't on it, and they were not. So pumping, we just queried that. So here we go, just increased risk of GI bleeds, ulcerations, and then same deal here. So while taking it, their blood pressure can possibly increase. So same deal, inflammation and bleeding ulcers. So when you combine a steroid anti-inflammatory with an NSAID, it does increase your risk of all the adverse effects of GI bleeds and increased blood pressure. So good to query that. But in this case, they were taking it, this probably almost could have been a major problem, but since that was done a month ago and it was only for a 5-day course, the likelihood they're still on it is very unlikely. Even though if they were to take them both together, the seriousness of the adverse event could be quite high, but the likelihood that they would still be on it is quite low. So I classified this as a minor problem, but it could have been a major one. Just depends really. If they were still on it, then it would be major. So as long as you basically confirm that they're not on it, it'd be minor. But for the purpose of this case, I've listed it as a minor problem and not a major one. So let's now go to the betamethasone cream. So dose interactions. So I've listed dose interactions from pretty much all of them. These are not the only things you have to check, but for the purpose of a case like this, where you can't really ask questions, they're pretty much the only things you can really check. But in real life, you'd be checking a lot more. So don't feel like these are the only things that you do check. Okay, so there wasn't really too big of an issue here, but I did have a few students message about it. Like I thought no one was going to say anything about it. So this student just mentioned it shouldn't be used longer than a week, and they would check how long they're using it for. A week is fine. A bit longer is also fine as well. It doesn't need to be that strict. I think they've got it for, maybe they've got that from a lot of the over-the-counter steroids specifically, right? No longer than a week. But you certainly see it used for a bit longer than a week in real practice. Same deal here. They're just saying that they want to see how long they're using it for. Make sure they have steroid-free intervals if they're using it every day, which is good. It minimizes the adverse chance of adverse effects. This comment was really good. Really impressed by it. So they're trying to think like maybe a little bit ahead. So they're saying skin irritation is a infrequent side effect. So I'm assuming they're thinking that potentially one of the other medicines could be causing the skin irritation, and then they're using the steroid to basically treat that. So kind of just masking an adverse effect of another medicine. So they're thinking a bit ahead in this one. So very unlikely for this to be the case, but it's good that they're thinking ahead. If it was another medicine that was more commonly caused skin irritations, then this would potentially be a major issue and they would have picked it up. But in this case, probably very unlikely. So just some minor things to double check basically. So far I only got the one major one, so it's pretty obvious that the next two will be the major ones. Let us go through them. So the dose is fine. I did have one student ask about it being high, if it was a starting dose, which is good to double check since we don't have as a lot of information here. Interactions. So if you plug this into a drug interaction checker, you would have got tons, which I think was why this was the most common major problem that everyone has picked up. So basically people are seeing the triple whammy pop up, and then they're also seeing a potential increase in blood pressure. So here are the comments that people are saying. So the triple whammy, you basically have meloxicam, irbesartan, and the diuretic as a combination does that effect. Same deal, people are just mentioning the triple whammy. This one's going into a bit more detail, so explaining it a bit, which is good. Really impressive comment. They're also querying their renal function, which is good. Same deal here, triple whammy, triple whammy, triple whammy, triple whammy, triple whammy. This one's mentioned blood pressure, which is good. Triple whammy. And my favorite comment as well has appeared again. So irbesartan, because kidneys will be cooked, and the Mobic can increase the counteract the antihypertensive medication. So make sure to be using this extremely technical, very medical language when you sit your exams. No, don't. Okay, so that is our second major problem. Now, just a quick reminder that the triple whammy is not the increase in blood pressure problem. These are two separate issues. So triple whammy refers to those three medicines potentially causing acute kidney injury. The increase in blood pressure is just a thing that the NSAIDs can do. So they're two separate issues that can get the increase in blood pressure without the triple whammy and vice versa. So these are technically two separate issues that you do need to look at, but I've listed them as one major problem. So this is our second major problem, the combination irbesartan plus HCT. So on to the very last medicine here. So the dose is appropriate, it's on the lower end, 10 milligrams. Any interactions, there's no real drug-drug interactions, not even really any disease-drug interactions. So how is this our third major problems? Basically, if we are taking meloxicam, we potentially could be masking an adverse effect of rosuvastatin. Do you know what that could be? It would be myopathy or rhabdomyolysis. So I'm sure a lot of you would have got that if I gave you that hint, but there were only a few students that got that. So there's the one that's picked it up. Here's one that I think picked up pretty much all of them. Here's a good one where they go into like the actual details of it, wanting to get their CK, liver function test, etc. So these are good, impressive comments that some of the students have been leaving, students or interns. Myalgia from the statins. So this was our final third major problem. Yeah, the third major problem. So I think and pretty much think it was only these 4 students that got it, and I did get quite a lot of students messaging me, but I'm sure if I left that hint, then the others would have got it, but something that probably should have been picked up regardless. So, okay, so how would I turn this into an OSCE or intern oral exam? So I mentioned at the very beginning that I was initially going to turn it into an OSCE or intern oral exam question, and then use it probably as part of my workshop or include it in my book maybe, but I decided to try something different. So it's a pretty easy thing to do, and I'll just go through how to do it just so you can see what your examiners are probably doing. I wrote this post quite a while ago. Basically, there's this concept that I kind of coined called a misdirection, and it's probably a big reason why most of the time you don't solve your oral exam. So often the very first problem that you see in an oral exam is not the main problem they're looking for. They've made it super obvious to draw your attention to that. So basically a misdirection, and there's another problem that you need to be trying to solve. So there's a QR code, scan it, and you can go to the initial article to read it all. I'm not going to explain into that much details, but that's the general gist of it. There'll be a big problem that is obvious, that is not the actual problem, and then they've used it to take your attention away from the other major problems. So in this case, it would have been very easy to use the triple whammy as your misdirection. So basically, I would have done, this patient has come into your pharmacy, this is their drug history, and then most likely a lot of the students or interns would plug it all in and then see the triple whammy, and then they would have just been focused on that and saw that they had found the problem that they were looking for, but it's not really, because you need to think of what they're trying to do in an exam situation. They're trying to test your knowledge, and if all you did was plug it into an interaction checker, that's not really a check in knowledge. That's just seeing how well you can plug something into an interaction checker. So basically, if an exam, they would have done that, you would have pretend called the doctor, and then the doctor would have said, yeah, it's fine. They're only using it for a few days and their kidney function is good, their blood pressure is good, so I'm not concerned. And then if you became too fixated on it, you would have missed the other problems. So in an exam situation, that would have misdirected you. How they would have drawn attention to the real problem is most likely what they do is they'll show a change or increased dose. So if you question this patient, you might have saw that rosuvastatin was brand new or it had been recently increased from 5 to 10. So then you would have had to recognize that that was causing their muscle pain. That's why they were prescribed meloxicam. You possibly would have had to recognize that they was still on prednisolone. So that was just to do with having good questioning. You possibly could have also had to question them, and then you would have realized that they had taken an over-the-counter anti-inflammatory, and that exacerbated their asthma. So that would have been around the time they first took prednisolone. And then giving them meloxicam would do the same thing, although less likely to because it's COX-2 selective, as we've just learned. So there's a lot of ways they could have hidden those problems, and you would have had to discover it via good questioning. So that's basically how it's very easy to turn it into it. So don't be too fooled that the first thing that appears is the problem. Sometimes it is, like, not going to lie, sometimes it is that easy, but often if it's super obvious, there's a good chance that it's a misdirection. So what would you do if you did not spot the problem? So if you did not spot the problem, there's probably two things happening. There's one where you either just did not know the information. In that case, if you're still studying, if you're in university, that's probably okay because you're expected to learn a bit more. If you're about to sit your intern exam in October, you probably should have already known all that information. There were certainly students that were picking up 2 of them, 2 out of the 3 problems. So if you're an intern, I would expect you to know 3 out of 3 since you have your degree already and you've already been an intern for 7 months now. But that's okay, you still got quite a lot of time to be studying. The other, if you did know it but couldn't draw it, then there's lies a problem in your ability to probably recall information. So you've not been testing yourself enough, which is often the case for a lot of these things. So you need to be testing your ability to recall information. And then if you're in the exam, so say if you were sitting your university exam or your oral exam and you did not spot the problem, you did not know the information, you would need to know how to find the information. That's often just via good questioning. So like what I mentioned in the previous slide, you need to draw your attention to stuff that have been changed or recently added. And then say if you didn't know that rosuvastatin could cause muscle pains, but you noticed that it was a new medicine or recently increased the dose, then if you went to your AMH and then read about it, you would have saw that it could cause muscle pain, and then you would have found it, even if you didn't know that it could cause that. So how do you do this? So the easiest way to get the huge amount of drug knowledge into your brain and train its ability to recall is probably via the Memorize Medicine website, so memorizemedicine.com. This is why I built it. It was based on what I was doing when I was an intern. So this will increase your ability to know drug information and the ability to recall it because you're testing yourself a lot. If you are finding problems studying effectively, you should probably check out this video. So this is one that I run for free for the Pharmacy Students Association. So if you're still in uni, get them to send me a message and I'll run it for free. If you finish uni, it is available via the Memorize Medicine shop. So I go through the scientific ways on how to study and how you can stay in your brain more easily. If you want a really good breakdown on a whole exam, this is the recording that I did with some interns last year in 2020. This is a very long, in-depth recording. It goes for almost 2 hours. Like I spend a lot of time with the students to make sure they fully understand everything and they're fully getting all the points and how to solve the exam. So have a good watch of that. It's very detailed breakdown of a lot of things. And finally, obviously what probably most famous for this book. So there are a lot of exams in here. I break down how to find the problems. I go through how you're being misdirected. And it's now, if you're using something like this, please do not just read it and then read the answer. You need to be training your ability to actively recall. else then you would not be able to get it. Not be able to get it, but your ability to do it in exam situation will diminish. So read the questions, try to solve them, and then read the answer, and then you'll find that you'll be able to start recalling things much more easily. So stay in touch. So if any questions, feel free to reach out. There's the shop if you want to buy those products. If not, doesn't matter. There's a lot of free content on my Facebook and Instagram that I'm sure you'll find valuable as well. Please make sure to share them with your friends. I do appreciate that. And if you like anything, please let me know. Lets me know that I'm doing the right things and where to focus my attention to. All right, guys, any questions, feel free to hit me up. Thank you. Oh, thanks for everyone that did send comments. They're really good. I did learn a lot from everyone. So even though I was helping you guys were helping me as well. So thanks to all the students that did send comments. I hope you didn't mind that I took screenshots of them. All right, latest guys, hit me up if there's any questions.